Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everyone, and welcome to another episode of the L.Ad.Phys podcast. My name is Dhinu Jayaseelan, and today we are joined by Stefanos Karanasios. He has a master's in advanced manipulative physiotherapy from the University of Birmingham, a master's in hand therapy from the University of Derby, and is currently working on his PhD in Greece at the University of West Attica. His primary research interest is the diagnosis and management of lateral elbow tendinopathy. He has been practicing for over 17 years, managing a range of musculoskeletal conditions, and has been an active member in the development of current programs and curriculum updates for IFOMT. Today, we'll be discussing one of his recent publications published online ahead of print with the Journal of Hand Therapy, titled Diagnostic Accuracy of Examination Tests for Lateral Elbow Tendinopathy, L.E.T., a systematic review. Stefanos, thanks so much for joining us.
Hi, everyone. Thanks a lot for your kind invitation. I'm very happy to participate in this podcast and happy to start the conversation.
So this publication kind of fits along with your main area of interest around lateral elbow tendinopathy as a product of your PhD work. I'm wondering if you can start by telling our audience why this topic is interesting to you.
Okay. This question is sometimes very difficult for me, and believe me, I am trying to answer this question frequently to myself to remind me where I am, where I stand. So it's difficult because I have to describe why I pass the last 3-5 years of my professional and sometimes personal life in the research of the assessment and management of this specific patient group, lateral elbow tendinopathy patients. So the critical point that triggered my interest was a significant gap that I found existing between clinical practice and research. So during the management of this patient group, as a clinician, I have experienced a lot of times in the past that a significant proportion of them are not responding to my best evidence of treatment plan. So I have applied everything I knew. I have tried to manage them at the best of my knowledge and practice. So still, a lot of patients did not respond well. So I have started becoming more critical about the research and what we are applying in practice. So what do we know about the diagnosis of this condition, about the proper management of this patient? So I start searching the literature further and further. And I realized that on one hand, the research evidence is sometimes very poor regarding the diagnosis of lateral elbow tendinopathy. Also, I identified several gaps in the best available management of the condition. So, all these factors led me to the research question in my PhD research pathway.
And you bring up a good point of, even though there's a lot of evidence, there's a lot of gaps still in the evidence. And even with lateral elbow tendinopathy, which has been treated a lot over the course of years, and there's a lot of investigations related to it, there's still a number of people that don't get better, even with the best evidence. So this is an important topic to kind of continue to pursue. With your paper, specifically the systematic review, can you give our audience who has read this or who has not read this yet a brief synopsis of what you did and what you found?
Yes, of course. My pleasure. So, the main aim of this research paper was to evaluate the diagnostic accuracy of any physical examination test and other imaging procedures for the patients with lateral elbow tendinopathy. For this aim, we have used appropriate guidelines in conducting systematic reviews, adhering to the PRISMA checklist, especially for the diagnostic test accuracy studies. So we searched the literature from inception to March of 2020, in all the available databases, great literature, all other resources that we could find. And using two reviewers independently, we have evaluated the results and applied all the criteria that were pre-specified and registered in Prospero. We have collected all the eligible studies, and we have used for the assessment of these studies the Quadas 2 checklist, which is the most updated version of quality assessment for studies for diagnostic test accuracy. Finally, we have included 24 studies. The majority of them have used the ultrasound imaging as the index test. So the test that was assessed for accuracy was ultrasound imaging with different parameters, grayscale, Doppler, and sonoelastography. A few of the studies that we have found evaluated the use of MRI, and only two studies have included physical examination tests. Our findings mainly revealed that ultrasound imaging has diverse and variable diagnostic accuracy. A wide spectrum of abnormal musculoskeletal findings have been included. So, other studies have used the assessment of tendon thickness. Other studies have used the assessment of focal changes. Others have included also the presence of tears or calcification, or even vascularity. At the end, some of the studies have combined these results. For MRI, also the results were variable, depending on the abnormality that has been used for the assessment of tendon-related changes. Based on our results, we have found that physical examination tests diagnostic accuracy is under-researched. The available evidence suggests that only two tests are widely accepted and well researched. This is the Cosen's test. This is the test that we are using isometric wrist extension test by palpating also the lateral epicondyle, provoking patients pain, and at the same time, the grip strength test, which was shown to be highly sensitive and specific when there is a difference between the grip strength in 90 degrees of elbow flexion and 0 degrees of elbow extension. So we have diversity on the results, variable results for the use of imaging, and limited results for the use of two specific physical examination tests. Despite that, we know for a long time we are using a number of tests either in our clinical practice or according to medical procedures for imaging. The evidence to support the use of these techniques is not quite strong.
It's good to have a synthesis of this evidence because what we do clinically doesn't always match up with what's actually out there in the evidence. And I think a strength of your review was that you use so many databases and you search the gray literature. So that reduces the risk of missing relevant articles. But it was still surprising to me that only two of the articles you found really had to do with physical exam techniques as compared to imaging modalities. And so, as you've noted in your paper, and as so many studies have come out, there's not always a correlation between symptoms and what you find on imaging. And so, a lot of people are asymptomatic, but they have tendinopathic changes on imaging. But then some studies have come out to suggest that asymptomatic people with tendinopathic changes actually go on to develop symptomatic tendinopathies versus people that don't have abnormal tendon structures. Mm-hmm. So there's obviously conflicting results and evidence. So then based on your findings, and aside from ruling in or ruling out other conditions, what do you feel like the role of imaging is in the evaluation and management of tendinopathy?
Mm-hmm. Interesting question, because many clinicians and researchers stay on the diagnostic side of the tests. So we have a lot of tests using for a long time, and suddenly a new systematic review finds that the diagnostic accuracy of these tests are not clinically important because they reflect only the diagnostic ability of a specific group of these patients of interest. when imaging is clinically relevant for tendinopathy, I think that imaging, apart from its value to differentially diagnose a condition that should be referred or it would be important to change our management on these patients because they do not respond in the treatment plan after a long time. So imaging has to offer us subgrouping prognostic values. For example, tendinopathy continuum is a relative recent concept in the last 10 or 15 years, have changed a lot our perspective of managing patients with tendinopathy. And we have tried to use this concept and to differentiate, to subgroup the stages of the patients according to several factors. Factors in or around the tendons. So the use of imaging in these different stages of the continuum model, I think, can be an important factor that can sometimes lead our lead our treatment plan, lead our ability to change our treatment plan for these patients. We don't know how imaging reflects these different stages of tendinopathy that we have to deal with in our clinical practice.
Yeah, and then if imaging gives us some information, but we don't know if it's relevant or not necessarily, something that oftentimes is relevant is what you can actually see, hear, feel in front of you when the patient's there and telling you something hurts or doesn't. And so a lot of times in tendinopathies, palpation has been used diagnostically to say, okay, it hurts here, so that's maybe more of the tendon versus something else. And so in your review, it didn't seem like palpation was a commonly used or researched diagnostic tool. But even with palpation, as much as it can be used diagnostically for tendinopathies, my fear with lateral elbow tendinopathy is there seems to be like a higher correlation with this tendinopathy than others with altered central pain processing. So widespread hyperalgesia is not uncommon with this group. Widespread hyperalgesia
Mhm.
potentially confounds the results of diagnostic palpation. So I wonder if palpation may or may not be relevant for this diagnostic purpose. What would you do in the clinic to try to help identify if lateral elbow tendinopathy is present or not?
Now you have to be more clinician than researcher. But in general, I have to state that from the research point of view, palpation is for a long time the gold standard for the diagnosis of tendinopathies and for lateral elbow tendinopathy. So from these 24 studies that we have included, the majority of them have used some clinical tests for the diagnosis, and in all of these times, palpation of the lateral epicondyle, positive palpation, so bringing patient symptoms, was the most usual reference standard. So this is another issue. This was, I think, the biggest limitation of our study. So we are using a specific test as a reference standard, and I think this is not the gold standard of tendinopathy because many times it can be a false positive test. As you said, in cases where we can have a widespread hyperalgesia, where in in lateral elbow tendinopathy, is very usual. It has been well documented that patients with lateral elbow tendinopathy present also widespread hyperalgesia. So this factor can be very misleading, especially when it is used as an outcome measure or even as a diagnostic for diagnostic purposes. So, in agreement with recent international consensus statements regarding tendinopathy, we should adapt assessment outcome measures during our practice, which should include physical, psychosocial, and quality of life measurements. So, as far the diagnostic perspective, history taking and description of the pain, how it started, how where it radiates over the elbow or to the wrist, and as far the physical examination tests The combination of 2 to 4 different tests, I think, is the most appropriate way to include the diagnosis of lateral elbow tendinopathy in our reasoning. And sometimes, if all of these tests are negative, I think it's very clear that patients have other issues that we have to further investigate. So the use of these clinical tests, apart from palpation, is the difference between pain-free grip strength in elbow flexion and elbow extension. It is the isometric wrist extension strength test or provocative strength test. It can be also the Miles maneuver, stretching the wrist extensors, and so on.
And in addition to the physical exam techniques, you brought up a good point that there's more to it that we need to evaluate and manage with tendinopathy specifically. But I would argue that's for all conditions, is that history taking is really essential, and the psychosocial variables that are associated with somebody's pain experience are paramount to measure. So those should not go unnoticed and should not go unassessed or measured. But still, in a peripheral pain condition, there's probably going to be a peripheral pain that you can reproduce. And if that's the case, then maybe it makes a peripheral condition more likely like this. So then I wanted to go back into your study a little bit, because with these systematic reviews, I always like that we can synthesize information and get these conclusions, and we have this high level of evidence to start trying to guide our decision-making process. But I also am cautioned when I look at systematic reviews to know that the conclusions are only as good as the quality of information the conclusions made from. And so when we look at studies specifically, it's important to look at things like the quality of the study, but also risk of bias. And so I like how you and your co-authors did a really good job of assessing risk of bias, but sometimes this is a component that gets glossed over for the conclusions of the synthesis of the information. And so can you kind of speak more broadly to why is knowing risk of bias so important in the interpretation of findings with the systematic review?
Yes, indeed. Risk of bias part of a review, I think, is the most challenging procedure. For us, it was also a little more challenging than the other times, because it was the first time that we had to deal with diagnostic test accuracy studies. In research, we are very get used to evaluate studies about effectiveness of interventions, and we know a lot about the factors that may be at the risk of bias in randomized controlled trials. So this type of research is different. We had to evaluate a number of factors using a new tool, considering the different aspects like patient selection, index test, reference test, and other factors affecting the way that the results were interpreted from the authors. So the risk of bias is a key element during reviews, because it will give the ability for the audience to take the messages based on the internal and external validity of these studies. So if the internal validity is high, so the methodology of the studies that have been assessed was strong and without many sources of risk of bias, then we can rely better on their findings. And then we can change practice more significantly. For example, in our review, we have found almost 90% of the eligible studies suffering from a high risk of bias in patient selection. Why? Because many of them have not excluded appropriately all the patients that are usually having lateral elbow tendinopathy. Maybe sometimes they didn't describe this factor at all. Other times they have used only patients, and they haven't assessed the use of these tests in healthy individuals. Imagine that you are evaluating the use of ultrasound imaging in patients, confirmed patients with a gold standard, and in a group of people that they do not have symptoms. So the false positive or true negative results will show how much we can rely our practice on using this kind of tests. If you are using these tests only in a patient group, the results will be sometimes weaker. On the other hand, apart from the internal validity, the risk of bias is strongly connected with the external validity of the studies. So the take home messages are connected with the flaws that may appear in these assessed studies throughout the reviews. Don't know if we are in the same line because I know also your background in reviews. So the risk of bias always is a key element.
Yeah, with every study, I always am optimistic about the results, whether it's a nil result or positive or negative result. But my intuition always leads me first to what are the limitations or what are the cautions with any study and how can it not be generalizable
Mhm.
before I first start thinking about how it can. And when you have diagnostic studies that don't use a comparative group of people that might not have the condition, that's a big red flag for me. So I think it's really important to not forget those components of the systematic review that sometimes go overlooked, in my opinion. And so another component of your study was obviously looking at people with lateral elbow tendinopathy, but lateral elbow tendinopathy is somewhat of a relatively newer term used in healthcare research, although it's been around for a long time. And we've been moving from tendinitis to tendinosis or tendinopathy more recently and effectively. Still, people are using different terminology. So I'm wondering, based on your search, which was done and completed just about a year ago now, did you get a sense of current terminology being used more frequently in recent publications?
Yes, yes. And this issue about terms is more evident in lateral elbow tendinopathy. So, for example, I think our study is not so visible because we use the most recent term lateral elbow tendinopathy rather than tennis elbow. So, in general, I agree with recent authors supporting that using tennis elbow, which is strongly related to a specific sport, is not very appropriate because it can be misleading for the patients or the practitioners trying to explain the condition to their patients and so on. So, in general, in lateral elbow tendinopathy is known with different names. Epicondylitis, epicondylalgia. We have passed through this period using the term epicondylalgia or epicondylosis, tendinitis, tendinosis. Tennis elbow is the most common. However, we have to be able to use a term that is more related to the symptoms of the patients and coming back to this tendinopathy continuum compared to a structural model of thinking about tendinopathy. I think is more appropriate to use the term tendinopathy describing the area of the symptoms, and also from this term, we can include variations where different factors may influence the pathology, including changes in the tendon or around the tendon or to the most proximal joints, or changes affecting the way that the patients recover. So, in general, I think the terminology now has been in the most appropriate direction. However, it needs a lot of time because many papers needing to attract the audience may use other terms that have been abandoned lately.
Yeah, it's always interesting to me when an injury or a condition is linked to a specific activity. And specifically with lateral elbow tendinopathy, I've seen a number of people with the condition, but I don't think any of the people I've seen with the condition have actually played tennis to actually develop the condition. So the term is misleading. And so hopefully at some point we can actually use the consensus statements, which I think are appropriate. But we still have to keep in mind that the same thing will be called different things. in this way. Regardless, it seems like there's a move from an itis to an opathy, probably because we know a lot more about the histopathology of the condition, and there's not as many inflammatory mediators probably in this condition more often than not. You published a systematic review recently in BJSM kind of related to the interventions for this condition, and you're investigating additional options as well. Historically, based on the evidence, it seems like exercise, maybe with or without mobilization with movement, has been a very common management strategy for lateral elbow tendinopathy. In your work, what are some findings that seem to be emerging and maybe promising strategies for the management of the condition?
Okay, maybe this is another very long conversation, possibly another option for a podcast. It's another long lasting work that has been published and presenting information about the effectiveness of exercises in this patient group compared to any other treatment, invasive or non-invasive treatment, compared to other exercises. So we have tried to check to evaluate if there is an exercise that is more effective than other types of exercise. The conclusions now. In general, exercises should be considered the primary treatment for lateral elbow tendinopathy patients. And this is based on the clinical superiority of exercises compared to corticosteroid injections, and also the statistically and clinically better results compared to other passive treatments. However, this effectiveness, these differences were very small. Again, there was a significant proportion of patients that after 1 year did not respond in any of these treatments, either exercises with or without physiotherapy, modalities or other techniques, or to corticosteroid injections, or even to a wait and see policy. So we know that exercises have better outcomes than specific passive interventions. We know that the magnitude of this effectiveness is small, and we know that there is no gold standard of exercise type that should be included in the treatment program. And strong question is how we can find a better way of treating these patients, how we can subgroup these patients, because as you said in your question, the mainstay of treatment approach is mobilization with exercises, or exercises with sometimes modalities like extracorporeal shockwave therapy, or L.Ad.Phys physiotherapy in the past. Other people propose the use of acupuncture, especially in the last decade. So the bottom line, we have to find alternatives and a way of producing prognostic factors of patients that will respond better to specific treatment approaches. The discussion about the most appropriate treatment changes considering the chronicity, the severity of the problem, the severity of the symptoms, and also the daily activities or workload, type of occupation, and other factors. So, alternatives, one of these is an alternative type of exercises, and detailed description of the stages about the type, the volume of exercises, the frequency of exercises, the use of different equipment during exercising were also the initiation of my research. That's why I have tried to evaluate a usual treatment plan, including exercises, with new approaches like blood flow restriction training in this patient group.
And I would agree that exercise is probably going to be the mainstay of any management strategy for a tendon problem, is to improve the capacity of that tendon and make it less painful. What were your initial results, and how is it going with your blood flow restriction study, if you're okay with sharing that so far?
Yes, I'm not going to share information about the results. However, I have to describe what my thoughts were and how these thoughts are changing during this experiment. So, in the beginning, my concern was that there is no definite exercise program for patients describing all parameters. So, in the same line with the previous answer about the exercise effectiveness, so I have tried to integrate a model of exercising treatment plan using stages. I have tried to compare in the main experiment the use of this exercise plan with and without blood flow restriction. Blood flow restriction was intending to change the present pain threshold or the general symptomatology of the patients during the rehabilitation process. At this point, I can see that there are some signals that this way of training can be beneficial. However, we have to wait at the end of the year to present details from this research.
As a final kind of parting shot, coming back to the diagnostic accuracy systematic review, because once we identify this is lateral elbow tendinopathy, exercise is probably our mainstay, but it seems like there's some emerging opportunities for some other interventions for this condition. But I'm going to ask you to put your clinician hat on, and I want you to think about what's the biggest take-home point that you'd want the listeners and our audience to know about this paper. What do you think is the main thing you'd like that group to know?
I would say that we have to use evidence, even if it is limited, tests for physical examination, like the Cousins test or the grip strength between elbow flexion and extension, because they present high sensitivity values. Also, the use of ultrasound imaging or MRI in the diagnosis of L.A.D. provides variable diagnostic accuracy. Hence, we should use them in certain circumstances when we have to differentially diagnose situations, especially when patients are not responding well in our practice.
I think these are important messages to take home, especially since it seems sometimes so simple to diagnose lateral elbow tendinopathy. But when you look at the evidence, there's not a ton really out there to support what we do. So it really does have to be a clinical reasoning framework that guides the decision. Based on your review, it seems like we should not rely as much on imaging to guide our evaluation, which hopefully ends up reducing time spent away from treating this person or the healthcare utilization of this condition. So I think this is a really important step in more appropriate and effective and efficient identification of this condition. So I appreciate you and your team working towards putting this together.
Thanks a lot for your kind words. I think our direction of getting the clinical practice more effective and closing the gap between research and practice using the most appropriate methods is a key factor and a name that we work all together.
Completely agree. And I completely appreciate you taking the time out of your busy day to chat about this paper, to talk about briefly some of the other stuff you have coming up. I know our listeners are going to benefit from having more of your thought process attached to this paper. So, Stefanos, I appreciate you taking the time. Thanks so much.
Thank you so much. Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the L.Ad.Phys podcast are those of the interviewers and interviewees and do not represent the official position of L.Ad.Phys. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.